Hello, everyone, esteemed guests. I am Jan Joly. It's my pleasure as the director of the Center of Genomics and Policy to welcome you all to the 2024 Bartha Knoppers annual lecture. The Center of Genomics and Policy is a founding pillar at the Victor Dahdaleh Institute of Genomic Medicine at McGill University. It's an interdisciplinary and international research center with a distinct focus on universal human rights that was funded at McGill University by Bartha Knoppers in 2009. And the Center of Genomics and Policy is dedicated to anticipating and addressing complex legal, ethical, and social challenge in the field of genomics and modern medicine through research, education, and practice in collaboration with local, national, and international partners. If you are a student interested in the ethical, social, and legal issue of genomic research, do look us up. We're always interested in finding the right student to expand our first-rate team. And on that note, I will let the research director, scientific director of the center, Professor Man Zawadi, introduce our speaker for the annual lecture.
Thank you, Professor Joly. Esteemed guests, good morning. Thank you all for coming. I have the distinct pleasure to introduce our speaker today, Professor Eva Winkler. Her bio is illustrious, so for the sake of time, I will do the abridged version. Professor Winkler has two main careers, one in medical ethics and another in oncology. She has a doctorate in cancer research from Heidelberg University and the German Cancer Research Center, as well as a PhD in medical and health ethics from the University of Basel in Switzerland. She leads the section for translational medical ethics at Heidelberg University's medical faculty, and her research focuses on applying ethical principle to real-world health issues and shaping health policies in research, clinical care, and public health. As a senior physician specializing in hematology and oncology, she is one of the governing directors at the National Center for Tumor Diseases in Heidelberg. Recently, she was appointed to the Ethics Council, advising the German Parliament, the Bundestag. And Professor Winkler is dedicated to advancing medical ethics and its role in research, healthcare, and policy. She supports the Academy for Ethics in Medicine as its vice president and serves as the elected chairwoman of the Central Ethics Commission at the Federal Medical Association. We are honored that she has accepted to give this year's Bartha Maria Knoppers lecture. Herzlich willkommen an der Universität McGill. Professor, vielen Dank.
Yeah, thank you very much, Man, and thank you for the center and the team for the warm welcome and the invitation and the honor to give this year's lecture. Kind of also the honor to Bartha Knoppers' pioneering work in health policy and ethics. We met in different initiatives years ago in the Global Alliance for Genomics and Health, and Bartha is also advising us in some of the German Genome Archive policy work. So there still is a very vivid discussion and mutual esteem, I would say. So for today, I'm delighted to discuss with you the topic genomic newborn screening as a very vital topic that merges medical potential and good things to come with complex ethical challenges. I will explore the ethical and social questions we have and try to address the question here, do we need a new ethics for genomic newborn screening, and what would such an ethics entail? So let's see. I will start with a kind of looking back review of the traditional newborn screening programs, its history and impact, and then look at the rise of genomic newborn screening, its potential benefits, but also ethical, legal, and social questions. I will start with the conventional screening criteria and how they might need to be adapted for genomic newborn screening and take a short detour also to the empirical stakeholder views and stakeholder studies that would inform such a program. And finally, I present, and that's my main focus, kind of an ELSI, ethical, legal, and social aspects framework for genomic newborn screening programs in general, but honestly also very much informed from the German context, obviously. So newborn screening is a cornerstone of modern public health, and it's one of the most successful public health programs worldwide, kind of identifying severe and early onset diseases in asymptomatic childs that then benefit from timely intervention is very impactful. Detecting conditions such as cystic fibrosis, SCID, or metabolic disorders right after birth has significantly improved the outcomes of the babies and the child. For example, for cystic fibrosis, it's an average of 25 years per patient that can be gained with a quite good quality. And you see other numbers for the other diseases. So the statistics kind of underscore the powerful health impact and early diagnosis and treatment. In Germany, we have in the official German screening panel 19 diseases. 13 of them are inherited metabolic diseases, and others have been added over time. And this is quite a long time. From the early days when Horst Bickel in Heidelberg, that's why Heidelberg has such a strong focus on newborn screening and still one of the centers for the complete south of Germany, discovered that the debilitating effects of PKU can be prevented by a diet. And Raymond Guthrie discovered a simple test to detect babies at risk. The newborn screening has expanded steadily, with recent additions including SCID, sickle cell disease, and spinal muscular atrophy. However, a new disease requires a lengthy approval process. For example, adding sickle cell disease took over 3 years to be on the panel, and genomic newborn screening could potentially streamline and expedite this process, allowing us to add new diseases more quickly. Other potential benefits are kind of obvious and directly for the child. We could kind of earlier identify a much wider array of rare diseases, providing timely diagnosis and treatment for the children, faster addition to the new diseases based on the evidence. We would learn and better understand the incidence and the kind of course of disease of rare diseases, and eventually maybe develop better treatments and informing precision medicine. Carrier status of the child's parents, if it is included in the panel, and that's a hot topic of debate, would inform kind of patients at risk and the family. And when it comes to cost effectiveness, we know that the current newborn screening program is very cost effective because it spares so much later on intensive treatment and saves so many years of quality adjusted life years. We don't know that and don't have the calculations because we also don't have the information on the panels and the different diseases on genomic newborn screening. That's still ongoing research process. And several centers and initiatives have already taken initial steps to explore the technical aspects and the feasibility of genomic newborn screening, also investigate the legal, ethical, and social frameworks. Here you see the US-based programs in the upper part, so North Carolina Nexus, BabySeq, Begin NHS, that's more for intensive care, children at intensive care units, and The Guardian. The European initiatives include Screen for Care. Genomics Inland has a large program with first setting up an information campaign and now starting to include parents. Baby Detect and New Lives is the German program, or the German research project. And I think that's important to highlight. To my knowledge, no country has so far embarked on setting up a genomic newborn screening as a public health program. All that we know so far is from research projects, and I just want to highlight that this is a really important distinction between setting up a screening program as a public health program and a research preparing this setting up of the program, because for the public health program, you have a really panel of targeted diseases. We don't have that in these research programs. They are explorative. At the moment, the median gene disease combinations on those in these programs amount to 500 and more, 700, 800 diseases. And interestingly, they almost don't overlap. So we had a mapping in our project, having the 7 large initiatives mapped on kind of concurrence and overlap, and only 53 diseases really overlap, and this is in one of the publications. You always need consent for research projects, and countries handle it quite differently, whether they ask for consent for the newborn screening. In Germany, we do have a consent-based approach, so the parents are asked after birth for consent. We still have, as you see, a very high participation rate of 99.9%, which questions quite kind of also maybe the consent process. So I think that's a stressful period directly after delivery, first 24 hours, and I myself, I couldn't remember that I consented to having this needle prick for my 2 children, but there are lengthy consent materials where you can really read through all the 19 diseases, and they are understandable if you want to read them. So that's just kind of for the outset, that's important that we are still in the research arena. And while the feasibility studies on feasibility and technical setup are kind of settling, I think we have just a recent JAMA paper that showed that this is feasible, and also sensitivity and specificity seem to be quite well. We do have a lot of ethical and legal and social questions that are vividly debated and not yet settled. And here are some of the, I think, most important ones. First on the disease selection. What are sound criteria and which criteria, and very specific criteria to select genetic diseases on the panel, on the genomic newborn screening program? How should, that's on the information process, how should the information and consent process for a genomic newborn screening should be set up in terms of timing, but also content? Should genomic data be archived for later use, or should it be deleted after the initial diagnostics? And then this all comes together in the question, how should a normative framework and best practice recommendations for a genomic newborn screening program as a public health program should look like? We approached these questions in Heidelberg with a research team with 5 different disciplines. Besides ethics and law, we had medical psychology for the informed consent studies and process, human genetics, and the pediatric team. And the research project in Germany is called New Lives, and that stands for Genomic Newborn Screening Programs, Legal Implications, Values, Ethics, and Society. And I report, obviously not my own work only, but of the whole team with the different disciplines. So what did we do? We first looked at how far we could get with the conventional criteria for screening programs. So the Wilson and Junger criteria have traditionally guided screening programs, and they focused on disease severity, treatment availability, test reliability, and cost effectiveness. And we found that they are a good starting point, but lack precision, applicability, and completeness for this specific area of childhood medicine and genomics context, and need to be kind of systemized, complemented, and adapted. And we started out with structuring them along 4 main topics. So we have the clinical, the diagnostic and therapeutic criteria, and then the program-related criteria, and group them in kind of these 2 categories. First, answering the question about sound disease selection criteria, so that the clinical, diagnostic, and therapeutic intervention criteria go under this rubric, and then the second separate management of the whole program and guide the ethical setup, the transparency, and ongoing management and evaluation of a genomic newborn screening program. Now towards the ethics. So what kind of ethical considerations were guiding us? So as we expand newborn screening to include genomics and in the field of childhood medicine, we need to integrate considerations from different field of ethics. We need the debate, we look at the debate of genomics-specific research and data ethics, also at the clinical ethics specific to the situation of pediatrics, kind of in proxy decision-making in the best interest of the child. It's not adult clinical ethics. Then we have the public health aspect of screening programs, and kind of the ethics of a learning healthcare system, which is also part of public health, but I'd like to highlight this separately. So what are the aspects and considerations that went in from these different fields of ethics? So first, specific questions of data ethics when it comes to genomic data. Since they are sensible data of informative value, not only for the child, but also for the genetic relatives, they need to be handled with care in a certain way. Data privacy is paramount, but also protection from misuse and looking at the informational rights. Then in terms of pediatric ethics, at the heart of any newborn screening is the best interest of the child. That also includes considering the child's future autonomy and the right not to know, and supporting parental responsibility and reducing stress and uncertainty for the parents. Third, the public health ethics aspect. Screening is a public health measure where benefit should always outweigh harms, but that's not trivial. Not only harms by false positive results, but also by medicalization. It needs a balance between the benefit towards children with rare disease, which are in itself rare, but also amount to many kind of percentage-wise then affected children, and the non-maleficence towards the healthiest children and solidarity with both of them. And then as a public health measure, kind of at the core of public health endeavors and screening programs, the access to such programs should be equal and should be granted. And then ethics of learning healthcare systems is actually part of public health ethics. I highlight it here separately because such a program is a learning process and needs to be researched and adapted over time. So since the question, do we need a new ethics for genomic newborn screening, lies at the heart of today's session, it becomes clear that we really need not a new ethics, but kind of an integrative approach to care for all these different fields and integrate these considerations. Now, before I share with you the results of this of our debate in our group and project, and what results we arrived at, I make a short detour to the empirical studies with different stakeholders. Our empirical studies were led by the Institute of Medical Psychology, Professor Dietzen, and are all aimed at informed choice. We have 3 different approaches. First, a focus group study on general opinion and needs of stakeholders, and stakeholders was defined as adult patient representatives having this disease, parents with minors and also healthy minors, and healthcare professionals, pediatricians and human geneticists. That was informing a quantitative representative population survey on the general attitudes towards genomic newborn screening. in Germany that has been completed but not yet completely analyzed, and then an online survey on specific attitudes and preferences of parents regarding the informed consent process and their opinion towards genomic newborn screening and their own child. That is still ongoing. And the aim is really to create decision aids, information material, and video tutorials that improve parents' understanding and reduce stress. And these tools should also promote health literacy and the respect for the different aspects, partners' values and emotions in the decision process. And that's also the focus of this Medical Psychology Institute, the dyadic decision-making in families. So that's really helpful to have a focus on that. So here you see the topics that came up in the focus group discussion that included parents of children, patient representatives and doctors. And we have just published the focus group results. If you are interested in more details, some of them are listed here in the perceived benefit and challenges from the perspective of parents, patient representative and doctors. Just to highlight some of them, preparedness was seen as a benefit by parents, and that's interesting because that also played a major role of some of the research projects to expand their panel from diseases that were confined to actionable diseases, providing a treatment and intervention afterwards towards also including diseases with no actionability, because parents said it's still an asset to know to be prepared or to have the opportunity to be prepared. Balancing the right of the child with the interests of the family was seen as a challenge, as well as the risk for overdiagnosis. So now these perspectives from my medical psychologists were fed into the discussion about the four main topics, as were the perspectives of the other disciplines. And we started out with a very broad debate and research also in every of the fields in this grid, and then ended with a real rigorous Delphi-like process when it came to the wording of the criteria. We arrived at 18, so Wilson and Junger were 9. We arrived at 18 criteria. 11 need to be met in order for a target disease to qualify to screening, and 7 additional requirements for setting up the program. So let me quickly walk you through them so that we have food for the debate afterwards. The clinical criteria, most importantly. So the first one is the causal association between a gene and a disease that not only needs to be proven, but needs to be definite or strong according to the ClinGen curation group. So that's a group that ranks different knowledge and gene disease association. And definite or strong are the 2 highest evidence levels. We decided that, ended up there for the reason to minimize harm by overdiagnosis. But any line you draw has also a drawback, and the drawback is that you don't learn a lot about gene disease pairs that are in a lower evidence level, which you would do if you include more. But we had a strict line, decided for a strict line here. Second criterion, penetrance. Penetrance is the probability of a disease that it really occurs in the person with a genetic variant. And we set a very high threshold here again, more than 80% penetrance. And also here it was the goal to minimize patients in waiting, having gotten a diagnosis and the disease never occurs because the penetrance is not high, and the uncertainty for the parents to deal with the situation. But we have to be honest, for many of the very rare diseases, we don't have a lot of data about the actual penetrance. You only learn about it if you start a screening program and see what the real penetrance is, and you most of the time also learn about attenuated variants that don't generate severe symptoms early on and have more light symptoms. We settled out in the average age of disease onset before 7 years. That's kind of the same strategy that all newborn screening programs more or less do, to only include diseases before school age. And here again, the idea is to avoid creating patients in waiting. And now it's really waiting, because if it's later in the teenage or later in life, adult onset, then you're waiting until it occurs. That's for one, and then the child becomes more autonomous and can assent or also consent to genetic diagnostics, so that this average onset is kind of limited to the age of where the child is not able to decide for herself or himself. And the downside is that we don't learn about later and adult onset diseases, and we would also not kind of speak to the need of the parents to prepare even for diseases that occur later on. So we posteriorize in a way the parents' needs. And the fourth clinical criteria is severity of the disease. We define that as premature death, major morbidity, and a significantly impaired quality of life, or modest morbidity with a significantly impaired physical or cognitive development. And this obviously is in the child's, or that argument here, underlying argument is that this would be in the child's best interest and the reason to screen in the first place. So the second group are the diagnostic criteria and the requirements for the diagnostic test. So the first one is that there should be a proven diagnostic advantage in adding this disease to the current newborn screening, either because you can diagnose the disease earlier, more reliable, or you couldn't diagnose it at all with the current screening, so a new diagnostic possibility. The second is highest reliability of the test result, meaning all affected persons, and only these are ideally found. It speaks to specificity and sensitivity. We would report only pathogenic or likely pathogenic variants, so no carrier status or variants of unknown significance. And this is kind of also more conservative approach to confine it to pathogenic variants, since we oftentimes don't know a lot about the actual pathogenicity of variants of unknown significance, but we would also not learn a lot about them. So it's really the argument to confine it as a public health screening program to arguments that kind of benefit the current knowledge, and that is a tension. It is less of a contribution to research, that you would learn more if you would include also more uncertain variants. Now for the and the last criterion, last criterion is a confirmation of suspected diagnosis by another testing method or an additional testing method that is really to minimize false positive results. So these were the diagnostic criteria, but it's not only about diagnosing diseases, but treating them and changing the course of disease. So we have also the therapeutic interventional criteria, and the first one speaks to it, that as a therapeutic intervention is established and available, and that this intervention can prevent the course of the target disease or can influence it in a favorable way. The 10th one is that this advantage is really one of starting earlier with the prevention and the therapy. If you have a therapeutic intervention, but it didn't make a difference whether you would treat a symptomatic child or the child just starting to exhibit symptoms, that wouldn't be an argument to put it on a screening list. So it really needs to be a benefit for earlier prevention or earlier start of therapy. And the third one, that the benefits of therapy outweigh its risk and burdens for the child. That sounds kind of obvious, but is not at all trivial. So we discussed that a lot, for example, for including cancer predisposition syndromes, which with a high penetrance that would check the other criteria. But if you then screen for that, you need preventive examinations of the babies and childs, for example, for retinoblastoma or for other cancers with an MRI, and you need general anesthesia to put the baby in the MRI on a regular basis. So there, the kind of burden and risks that come with the preventive schedule is kind of counterbalanced if you detect a retinoblastoma or another cancer early and can cure it. But there you see that depending on the disease, this is not an easy weighing of benefits and burdens, and you really have to discuss what is in the child's best interest here. Now, the second block set of criteria define how the program should be set up. First, and obviously, for reasons of justice, fair and equal access to screening should be the goal. And that means foremost costs for the screening, but also interventions that follow from the screening should be covered. And the second part of it, it's not only about cost coverage, but also knowledge, is really that parents are prepared for decision making and understood what it's all about. And we think that it would be good to introduce start the information process before birth. In the third trimenon, we have a mandatory birth planning visit, and that would be a good time point to introduce the information and give the parents also enough time and no stress to digest the information and make up their mind, and then the decision is made after birth. And we also recommend to separate it from the established conventional newborn screening, where we do have the information after birth, and we have this high acceptance rate from 99.9%, so we don't want to jeopardize this one with the uncertainty of genomic knowledge, and would separate these two information blocks. The 15th and 16th criteria speak to the analytic workflow and the secured communication routes for results. We have clear guidelines there. They are also laid down in the Genetic Diagnostics Act. Within 24 hours, you need the diagnosis, and then there is a clear communication route back to the doctor and the family or the parents. And we recommend to use the same routes and also have it quality certified in terms of laboratory knowledge and so on. That's more on the technical, but it's an important part. An important part of newborn screening programs is kind of always improving this analytical and communication process. The seventh criterion addresses the question whether genomic data should be stored for secondary use. And we arrived at a balance of those arguments that would improve the program in terms of the results should be stored for quality control. So the diagnostic results, the lists of genes, but the raw data will be deleted, except if an additional consent has been given from parents for secondary use for research purposes. So we also separate here the healthcare. The idea is to separate the public health screening program from a research world. And this has kind of systematic reasons, but also that we know from studies that parents are very reluctant to give consent to an unlimited storing of genomic data of their babies. So that should be really specific for research purposes and then explained why we need the data for what kind of research. And the last criterion speaks to the evaluation of the program with regard to quality, acceptability, and re-evaluation of targeted diseases. That's in great interest also of patient representatives and groups, so that we can re-evaluate and add diseases, or maybe also remove some if we see that the attenuated variants aren't as problematic as the ones that we know about. So that there's an ongoing re-evaluation process. But not only medical, also in terms of ethics and what needs to be adapted. So these are the 18 criteria that we think should be met embarking on a genomic newborn screening program. We are in some areas rather conservative, for example, in that we have high thresholds and independent thresholds. Other programs have a scoring system that all need to be met. So the gene disease association, strong and definite penetrance, more than 80% variants, likely or really pathogenic variants only. And the argument behind is really to minimize psychological and physical burden to the child and parents by reducing uncertainty and patients and parents in waiting. And we are aware that this somehow also limits research and resulting benefits from research, but would think that this should be a separate kind of consent and not combined with a public health program. So in summary, genomic newborn screening does indeed call for a new ethics, if you want to call it like that, also at least one that is equipped to handle the unique questions and challenges posed by this combination of genomics, children's medicine, and public health program. And specifically, the framework focuses on the informational rights, the child's best interest, to minimize the risk of overdiagnosis, granting equal access. It also underscores the need for comprehensive counseling and decision aids to help parents to navigate this complex information. And in doing so, we aim to support a screening process that respects the child's autonomy and minimizes psychological impact, and ultimately, hopefully, promotes a balanced, ethically guided approach to genomic newborn screening. With this, I thank you and the New Lives group, and especially Carla Alex, who was at the same time now in the last week with me preparing a talk, and we worked together at some of the slides, so I want to grant her this. And here you'll find more information and also the link to the publications of the process. And now I thank you for your attention and your thoughts about it.
Thank you, Eva. Can everybody... Okay, Mike, good. So first of all, thank you for such a nice lecture, and I really like the way the program was designed. And actually, I was curious before even opening it to question, when you started discussing about the consultation mechanism, Eva, that you undertook from the more qualitative, quantitative survey and then Delphi, how long did those activities take from beginning to end of the process, of this consultation process?
So the focus groups we started 2.5 years ago. And for the quantitative study, we were lucky that this is as a population-wide survey that is repeated every 5 or 10 years. So we could introduce our questions and panel questions, therefore it was quite fast. It was all set up, and we could add a new topic. And the interesting part is that the genomic newborn screening obviously was not on the last survey round, but prenatal testing, for example. So we could, if we have the results analyzed, we can also match attitudes towards that with a very different, and you always have to be clear that this baby is already there. It's not about prenatal testing, and see how this relates to each other. And the other one is still ongoing, and we also have already video tutorials made on genomics, and this would be now additional videos on this genomic newborn screening. So, yeah.
Really interesting engagement process, really nicely sophisticated with a variety of activity. I really thought that was fantastic. Are there questions for Eva? I'm sure there's plenty, and I don't want to take all the time. Okay, so I have 3 questions. We'll start by the back. Start by the middle. Okay, and then please, if you don't mind identifying yourself and asking the question.
I just get a pencil to write down the question.
And I think there's a button you need to press as well to activate. That's not. Here's what you need.
Great. This is a request? Anyways. Okay. Anyways. So my name is Bettina Mucha. I'm a medical geneticist, and I'm involved in prenatal testing and seeing kids and the newborn screening program here. So in that activity, we see already the problem with consenting pregnant patients with NIPT, for example, the limitations of the testing. We see the problems when we see kids referred that had been genetic testing ordered by other specialties, pediatric neurologists. So I think we have to go with the times, and it's just a matter of time until we go to genomic newborn screening. But I'm very concerned about implementation of the consenting process, especially for populations that are more vulnerable, immigrants that speak different languages, have a different social and maybe educational background, and then putting that burden on non-genetic professionals, because you said it's going to be in the planning. It's probably the planning visit for the delivery. So those are presumably obstetricians, midwives that don't have that same background. So I'm a bit, that's one of my big hesitations, the question about informed consent, then return of results, false positives, all the additional work that then goes to the medical geneticists and the counselors who have to deal with this. So how that's a lot of extra work for colleagues that are already pressed hard for time. So I don't know if there's a provision then to add more resources. How is that financed? All of these questions.
Yeah. And that's why we have it on this, why the program-related requirements are so important, not only to get the science right in a way, be kind of reduce likelihood of false positives and so on, but then to have enough resources to consult and really help health literacy. And I completely agree. This is a major task. So what we do is first we have a strong focus on that in our project. We have patient representatives that were from the large, not only PKU, but also the Children's Network from all the different rare diseases, from the kind of a co-design. So they are very active. We are now translating the criteria and the requirements and the justification and arguments in simple language. First in German, but then also in other languages. And we don't have genetic counselors in Germany, so this profession is not available. And we have a strong also argument that we really need a larger workforce to to do that, and we try to kind of communicate this also on the level of for example, the Society of Human Genetics. There's an own working group on genomic newborn screening, kind of to communicate this to politics, that this really, it's not only in genomic newborn screening, you have this in oncology as well, in cardiology, you have all these fields where you have more and more genetic knowledge to be explained and transported, but apart from this basic trunk, you need special knowledge that you need to cover. And then, so there were preliminary studies on what these video tutorials could help, and that was really helpful for the parents who are on genetic counseling process, and also the genomics diagnostics that we do in cancer. But it's only one puzzle in the information process. But you're completely right. That's a large task, and it's not something that you say, well, now we have everything set up. Now the information comes as the last thing that should also be done on top of what doctors have to do anyway. Yeah.
Thank you very much. My name is Vincent Muser. I'm an internist interested in genetics. I find the topic absolutely fascinating. My questions, I guess, are numerous, but have you got an estimate of the number of diseases and the cumulative prevalence of these diseases? That means which proportion of tests will necessitate a return of results? And have you considered chatbots, AI-assisted chatbots, for instance, to return results? I was in Denver, maybe you were as well, at the ASHG, and I was fascinated by these talks showing that these automated chatbots perform probably as well as some genetic counselors, which was very unexpected for me. Thank you.
So in terms of prevalence, it depends a little bit on the kinds of, what kind of diseases do you allow to be on the panel. It varies in the studies between 3.7 was in the JAMA publication and towards 10%. But the prevalence is not the only question. What you really want to know is what, like in the newborn screening, what is the difference in outcomes for those screened? And there we don't have a lot of data yet. What we do in our project is first in retrospective study of the last 10 years, because we have access to all the newborn screening data of children at the intensive care unit, where you would have, so in a matched pair analysis, where you would have benefited from knowing their disease earlier on, so to get a handle also on, or an impression what the real impact is on health outcomes, and not only diagnostic yield. But I think these questions are all in these different projects not yet answered. For babies at the intensive care unit, 80% of the reasons why they are there are genetic reasons. That's what I learned from our pediatricians. And the NGS Begin project from Stephen Kingsmore, he has kind of set up a really fast-track early ad hoc genetic whole genome sequencing. Within 48 hours you have the result, and has very good, it has a large impact on the family. So in former times it was the second child who benefited from the disease of the first one, but now he had many cases where he could detect what's going on when the child is arriving at the intensive care unit. So I think we also have to differentiate. These are symptomatic child; they are at the intensive care unit, and those who are asymptomatic, and what their benefit is. Yeah. And for the chatbots, we also have a study in planning, whether they are helpful or not, but I'm curious to learn from others whether they found this information, and asking questions and getting answers targeted to the kinds of questions have worked well in other settings. I write that down. Yeah, I know her.
Okay.
I have to look up every now and then.
Thank you, Professor Winkler, for a really very comprehensive and very interesting presentation. To me, it's actually quite radical because the basic premise of screening has always started with the availability of therapeutics. So you start with therapeutics. So PKU started because of the observation if you restricted the diet, you had a better outcome. So looking at a public health approach where something where you don't have a therapeutics, to me, is a little bit difficult because I think it's sort of open-ended and you don't know where you're going to go. I'm even worried when they have therapeutics that if you're going to take diseases and move towards a molecular classification rather than a biochemical or analyte classification, with drug companies trying to push their product, you're going to be treating a lot of people with variants that don't need treatment. So even sticking to the things where we have therapeutics, I think it's hard enough. So what is your timeline to making this a public health approach for all of Germany, for example? Is there something that's going to... So I can see this as a research project, but in terms of even what Dr. Mucha is saying, the infrastructure you need to actually follow the people long enough, especially when you have variants and no analyte marker or biochemical marker or functional marker. How do you set up a system where you actually follow up your, quote, presumed positives with, to see whether you're actually doing... I mean, it's like we have a country where people don't have 30% of people don't have primary doctors. So how do you incorporate this type of very forward thinking into a system that's already strained when you're not even offering therapeutics?
But I'm completely with you there. But that's one of the requirements and preconditions, that there is an established intervention available that really has an.
So because that wasn't clear because you were.
No, that's one of the clinical. The first clinical. I go back here. The first first the criterion 9. So that there is an established intervention available, not only established but available, not in a research study in MD Anderson, but really in Germany available for the disease to be treated.
So that's where you start, by compiling a list of diseases where there are therapeutics available.
Yes, completely with you. And we have the, so since those who do the current newborn screening are in our project, and they have all these concerns, well, don't we generate patients that are not patient, will not be patients? How do we make sure that there's a follow-up and nothing, if there's a positive result, that nobody gets lost, but also to avoid false positive results? And that's the entry point, that there needs to be something that changes the course of the disease, either by curing it or by relevantly improving the outcome of the patient, very much like the current newborn screening. And that would also reduce the numbers on the list significantly. Variants of unknown significance wouldn't be there. And if it's not likely pathogenic, it's also not making it on the list. Yeah, but these concerns are very valid, and I think have to be also taken decisive for our approach. Yeah.
Yes, hi, I'm Denise Avar. I was a retired researcher formerly with the Center for Genomics and Policies. I'm jumping ahead. First, I want to thank you for a very courageous and thoughtful analysis, because you're trying to tackle a world complex problem. And I'm maybe jumping a bit more. My question is a bit more mundane, but assuming that what we've just heard, the need for greater input from the healthcare professionals, and you did mention in your criteria the importance that if it becomes a program, it's accessible to everyone, and it's, in other words, the cost. I guess I'm not an economist, but I know that nowadays we face that question all the time. Is there someone working with you to try to analyze that at the moment, and what are some of the...
And I didn't answer your question on the timeline. So that takes, we need to know a lot of more details before this can become a program. This is just the the starting out of what would be selection criteria and what all we need to look at as a public health program. And the economical, so the cost-benefit analysis and cost-utility analysis are not yet made because we even don't have the data from feasibility and what kind of, so what are the cases. But the next step would be a multi-center study with really setting up a list of diseases. We just have the criteria and not the disease list. Other research projects just came up with the disease list of 700 diseases, and depending a little bit on the knowledge, they have more cardiology or more neurology, and so we first need the disease list, and then we will have the first 1,000 parents ask, and we learn a lot about the informed consent process, and there it's the economical analysis will be an integral part of it. And where the sequencing costs are going down, but the costs for consulting and interpretation, they will go up. So I'm very curious how this analysis will, what results they will need. Yeah.
So we are taking one last question, but there will be time for people to speak with Eva after the presentation of the prize. So.
Thank you so much. Thank you, Professor Winkler, for giving this very interesting talk. My name is Yumi. I'm a pediatric resident in training. So this is a very interesting topic to me. To remain factual, I'm just gonna take my notes, what I've written down. So in one of the criteria, you talk about a target disease that can be prevented or its course can be favorably influenced. Well, I've been working in more peripheral hospitals with a lot of cultural diversity, but also different religious beliefs. And it was already a challenge with the current newborn screening to implement it. And I had a lot of patients decline it as well. And I think a part of it is understanding the medical language behind it. So I'm curious how you will try to overcome that by even expanding the current test.
Yeah, well, for the current screening, we have a high acceptance rate, so we don't, but maybe we don't have a lot of discussion also. So the starting point, it's a very accepted public health measure in Germany. But I agree, you need to make this clear what the benefits are, and that you really screen for severe diseases, so that the child, if it's positive, and there's only a very small proportion of childs expected to be positive, you're talking about 3 to 10% of those screened, that they really live longer, have less, have a better quality of life or less impairment in terms of development. And it explained this in a very simple non-medical language. That's why we have now the first step would be to have our criteria translated into simple language, but also have the video tutorials illustrated in a way that you can understand what the purpose is and what also the uncertainties and risks are that you can't avoid even if you try to optimize this in a learning process. And that's an interesting point. So I think if it's really beneficial and the parents, because Bartha and colleagues wrote this, right, for an asymptomatic child to be found. So then is it upon the parents and their religious beliefs to kind of that's an interesting tension and discussion to modify this right and say, no, for my child, that shouldn't be the case. And how do they live with having made a decision with a child that could have been screened and found and it's not because they said, no, we only vote for the conventional but not for the add-on, or we refuse newborn screening altogether. So I think that we have so many questions that we need to integrate and tackle. And the timeline, even in Germany, would be 5 years and more. That is, I think we are starting out.
Thank you, Eva, for bringing up that point and for asking the question, because you did mention in your presentation that the conventional screening will continue. So this is an add-on with a higher degree of informed consent and intervention and so on. Whereas, as you mentioned, the article and co-author up there is Anna Bonilla, a master's student here in genetic counseling at McGill. I always think it's good to salute our pioneering students. And the argument there is that to find the child at risk has nothing to do with parental rights. It has to do with the child asymptomatic at risk in a big population to be found. Then all the other stuff, cultural, legal, ethical, and everything. So this is a separate right of the child. And I think, your first slide and so on, this is really inspiring because it's thoughtful, it's well researched, it's thought out, and it's prospective thinking on how to make sure the conventional screening, which is a child's right, is not affected by the added value, or maybe not, of genomic newborn sequencing. This is a public health. We have to get away from our individual stuff. This is a public health program, It's in the interest of the population of newborns, and that is you don't have those kind of conversations when it's always privacy, autonomy, and all the other stuff, So this is something we really are looking forward to reading more about. Thank you for being a pioneer. We know about all the other research projects, but at the international meeting 2 weeks ago, they didn't have that kind of research that you're doing with focus groups, with parents, with geneticists, and with economists eventually, that I think is necessary before we touch something that is the most successful public health program in the history of the WHO. So I'm really pleased to have a pioneer here in one of my favorite areas of child's rights. And on behalf of the Center for Genomics and Policy, and as Eva said, we met maybe a decade ago, and we're working on founding the Global Alliance for Genomics and Health. A real honor, a privilege, someone thinking way ahead in a thoughtful way. So from one fellow researcher to another, thank you.